Hello everyone, happy to be here again. This is Dr. Leila Mustafi. I'm international trainer in obstetric gynecology and midwifery and founder of Lillie Excellence Center. Today I'm going to talk about bacterial vaginosis. I hope you like this session, and I'd like to know if you like this session. Please, if you like, don't forget to like, share, and subscribe our channel, Lillie Excellence Center. Thank you so much. Let's start share some of our PowerPoint with you guys. Okay, what is bacterial vaginosis? Bacterial vaginosis is one of, Bacterial vaginosis, we are going to start to talk about it, have some introduction, some overview, presentation history, DTX, workout, treatment, guideline, medication, and follow-up. So what is bacterial vaginosis? Bacterial vaginosis was named is because of bacteria are the etiologic agents and an associated inflammatory response in lacking. Many studies have demonstrated the relation of Gardnerella vaginalis with other bacteria in causing BV, such as Lactobacillus, Pyrrhotella, or Anaerobis, and the others, as you know. So, we want to talk about its signs, symptoms, physical findings, and risk factors. Just I want to have a very short overview in this part, and we will go to talk in detail. What is the overview? As you know, there is some signs and symptoms. Typical symptoms of bacterial vaginosis include this following: vaginal odor, mildly to moderately increased vaginal discharge, vulvar irritation, and dysuria or dyspareunia. What about physical findings? Physical findings in BV may include this following: grade, thin, and homogeneous vaginal discharge. We have normal or appearing labia, intertus, cervix, and cervical discharge, and in some cases, evidence of cervicitis. There is some risk factor that we have to think about that. When some client and patient comes to us, we have to observe about this risk factor. Recent antibiotic use, decreased estrogen production of the host, wearing an intrauterine device, dutching, sexual activity that could lead to transmission. So don't forget, for all of this, you have to take very, very accurate physical examination. There is some microscopic examination that for diagnosis we need to go through that. As you see in this first picture, you will see the demonstration of Crucial on a saline smear. And here you will see a pH greater than 4.5 up to 90% of the patient, they will have the same pH. And in this third picture, characteristic thin, gray, and homogeneous discharge. Plus, if you want to diagnose positive leaf test, up to 70% of the patients will be very helpful. And Nugent's criteria. As you see, I keep here different picture. As a lactobacillus score is 0 to 4, as you see in this picture. Here you will see bactericidal Gardnerella score 0 to 4, and I kept the picture here as well. And here is Mobilinus, score 0 to 2. Total score are calculated and interpreted as follows. If you have lactobacillus, score will be 0 to 4. If you have bactericidal Gardnerella, it is score 0 to 4, and Mobilinus, it is 0 to 2. Okay, let's go for the next slide. Okay. What about the management? For the management, you need one clinical history: age, vaginal surgery, contraceptive, antibiotic, previous vaginitis, and treatment received sexual activity. About gynecological examination, as you see here, visual vaginal examination, including speculum, erythema in labia minor, or introitus, discharge and its characteristics, pain and erosions. In general examination, as you see here, we have to look after seeking sign of some systematic diseases. And for complementary examination, we have discharge pH, swab, and other microbiological procedures. And what about for the treatment? For treatment, as you see, for trichomoniasis, you will go through vaginal or oral metronidazole, mycosis for vaginal or oral azelaic derivatives. For Gardnerella, as you see here, it is vaginal or oral metronidazole or clindamycin. And if you have atrophy, is regular sexual activity, non-hormonal lubricants, and estrogen vaginal cream. And the squamative inflammatory vaginitis, the treatment is here. Clindamycin intravaginal cream, 2% to 10%, hydrocortisone intravaginal cream. How to take the history? As you see, we have 3 parts for taking history. First of all, we have to look for vaginal odor, as you see here. Second is vulvar irritation, and third is dysuria and dyspareunia. In this picture, you will see exactly itching or redness, as you see, grayish, white, or yellow discharge, fishy smell, vaginal bleeding after sex. And as I talked before about risk factor of bacterial vaginosis, unprotected sexual intercourse, women have sex with women, dutching, presence of other STI, cigarette smoking. And about physical examination, vaginal discharge. As you see in this picture, I'll show you exactly when you see the feature of cervix with your speculum. Most often, as you see here, is gray, thin, and homogeneous. You see here, adhered to the vaginal mucosa, may not visualize pooling of discharge in the posterior fornix because of adherence to this part, and may observe a small bubby mucosa in discharge fluid in this, as you see here. Differential diagnosis for BV. We can find for candidiasis, cervicitis, chlamydial, genitourinary infection, gonorrhea, herpes simplex, trichomoniasis, vaginal candidiasis, and vaginitis. For workout, we go through laboratory studies, obtain historical information regarding the patient's symptoms and nature of discharge. Patient may report this following. Most patients experience a vaginal odor or an increase in vaginal discharge. Vulvar irritation may be present or absent. Dysuria, dyspareunia, and abdominal pain are lacking. In vaginal examination, you will find a vaginal examination including the following: typical BV discharge characteristics, lack of significant vulvovaginal inflammation. And as you see in microscopic examination of the discharge, in this picture I show you exactly. As you see, clue cells in normal saline, true pH greater than 4.5, and characteristic discharge appearance and whiff test. And as you see, you will see we are looking for microscopic evaluation of the bacteria flora, vaginal culture, and diagnostic too. Here is the table if you want to find the difference between diagnosis of vaginitis. As you see here, we have bacterial vaginosis, trichomoniasis, and vaginal candidiasis. Symptoms are different. As you see, in bacterial vaginosis, vaginal odor is available. Trichomoniasis, sometimes there is, sometimes is not. But in vaginal candidiasis, we don't have any odor. Other symptom, vaginal discharge. This is thin, gray, and homogeneous in bacterial vaginosis. This is green and yellow in trichomoniasis, and this is white and cold-like in vaginal candidiasis. Vulvar irritation in bacterial vaginosis, there is some not. And trichomoniasis, there is, plus in vaginal candidiasis is seen. Dyspareunia hasn't seen in bacterial vaginosis. Trichomoniasis available, we will see, and vaginal candidiasis you don't see. About the sign, there is no sign of vulvar erythema in bacterial vaginosis, but sometimes in trichomoniasis there is and some is not. Plus vaginal candidiasis, this is different. Sometimes you will see and sometimes it's not available. Bubbles in vaginal fluid. In vaginal bacterial vaginosis is available. In trichomoniasis, some is not applicable. And there is no bubble in vaginal candidiasis. About strawberry cervix, it doesn't appear in bacterial vaginosis. It is sometimes available, sometimes is not, and there is no evidence in vaginal candidiasis. And what about microscopy? As you see, in microscopy, in bacterial vaginosis, we have clue cell, but we don't have motile protozoa. There is no pseudohyph, and we can use whiff test, and pH is more than 4.5. In microscopy of trichomoniasis, there is no clue cell. There is some motile protozoa. There is pseudohyph. There is not any pseudohyph, and there is sometimes whiff test working, sometimes it's not working. pH is more than 4.5. And in vaginal candidiasis, as you see, in pseudohyph is working, but whiff test doesn't work for that, and pH is less than 4.5. Okay. And what about the treatment? Treatment, there is some approach consideration. Inpatient care is not necessary for patients with bacterial vaginosis. Obtain culture of blood and infected tissue if visible from inpatient who develop obstetric, gynecologic, post-operative fever or sign of infection to try to elucidate the infection etiologic organism. Blood culture may not demonstrate growth of Gardnerella vaginalis unless gelatin is added to the media to prevent inhibition from the anticoagulant, sodium polyethylene sulfonate, and SPS. About antibiotic, studies are typically applied and orally administered yogurt lactobacillus preparation. Some women with recurrent cases of BV may benefit from evaluation or treatment of G. vaginalis colonization in their sexual partner. Treat BV occurring in pregnant women, wash only with hypoallergenic ball soaps or no soap at all, and consultation. And about diet and activity. Studies are conflicting regarding the efficacy of a diet supplement with lactobacillus, like acidophilus. Vaginal probiotic product, 8 billion units of lactobacillus rhamnosus, L. acidophilus, or Streptococcus thermophilus per capsule, that is for current bacterial vaginosis prevention. It's like short-term use of 7 days on, 7 days off, then again 7 days on. There is 9 best probiotic for vaginal health. One is Elm and Rye probiotic, one is Probiologic, Garden of Life Doctor, and many available. I don't want to advertise any of them. As you see, the name, some of the name I mentioned here. And what are the different strains used in probiotics? First, Lactobacillus rhamnosus. This is one of the most effective strains for vaginal health. It can help prevent and treat BV, yeast infections, UTIs, and other vaginal issues as well. Second one is Lactobacillus acidophilus. This is another common strain of probiotic. It can help prevent UTIs, yeast infections, BV, and other vaginal issues. The third one is Lactobacillus reuteri. This strain is effective in treating BV and yeast infection. It can also help prevent UTIs. Okay. So, what about clindamycin? One of the medicines we are using is clindamycin. As you see, this dosage, there is a capsule of 75 milligram, 150 milligram, and 300 milligram. It is available as an injectable solution, 150 milligram per ml, or oral solution, 75 milligram per ml. Even there is intravenous ready-to-use solution, 300 milligram per 50 ml, 600 milligram per 50 ml, and 900 milligram per 50 ml. So for bacterial vaginosis, this is 300 milligram per orally every 12 hours for 7 days. For pelvic inflammatory disease, this is 900 milligram IV every 8 hours with gentamicin 2 milligram per kg. Then 1.5 milligram per kg every 8 hours. Continue after discharge with doxycycline 100 milligram PO every 12 hours to complete 14 days of therapy. And for Bacterial Vaginosis, this is PO 300 milligram PO every 12 hours for 7 days. Second medicine is metronidazole. As you see, there is a capsule of 375 milligram, tablets of 250 milligram, 500 milligram, and tablet extended release 750 milligram, infusion solution 500 milligram, over 100 ml, tablet extended release 750 milligram, and infusion solution 500 milligram per 100 ml. In anaerobic bacterial infection, loading dose is 15 milligram per kg IV, not to exceed 4 milligram per day, and maintenance dose is 7.5 milligram per kg per IV over 1 hour every 6 hours for 7 to 10 days, for 2 to 3 weeks if it is severe. And in sexually transmitted disease prevention following sexual assault, 2 gram PO as a single dose, and 3 drug regime that also includes ceftriaxone or cefixime, plus azithromycin or doxycycline, CDC STD guideline 2010. For pregnant women, this is 500 milligram PO PID for 7 days, or 200 milligram PO TID for 7 days. For metronidazole, we have different treatment for colorectal surgical infection and pelvic inflammatory Gardnerella infection. But for this PV, 250 milligram PO every 8 hours for 7 days, alternatively 375 milligram PO every 12 hours for 7 days. And 2 gram PO every day, single dose, and alternatively 1 gram PO every 12 hours for two doses. It was about metronidazole, and we have SECNIDAZOLE for treatment that we can use for 2 gram a packet, and for bacterial vaginosis in female, 1 packet 2 gram of granule PO once as a single dose without regard to timing of the meals. So for the bacterial vaginosis, we have to go for further outpatient care, PV that does not dissolve after 1 course of treatment. Women with recurrent episode of PV, they should go for deterrence and prevention as well. As you see, this is the flowchart that I talked about that before, and this is the question I want you to answer. So please don't forget, for next class, I want you to answer this question. How is bacterial vaginosis diagnosed in post-operative patient? Second question, what are the treatment options for bacterial vaginosis or BV? Third question, what are specialist consultation needed for the management of bacterial vaginosis? Next question, what is the role of lactobacillus in the treatment of bacterial vaginosis? And last question, what activity modification are needed during the treatment of bacterial vaginosis? And next question, I keep here. Please look after that, and I want to discuss about that for next class. If you like this course, please don't forget to like, share, and subscribe to this channel, and write your question in the comment. I will answer to you. Thank you so much, and hope to see from you guys. Have a nice day, enjoy, and see you soon.